Hi, my name's Louise Kavanagh. I'm a GP at Park Medical Centre in Hammersmith, and I'm a GP trainer on the Imperial Scheme and a GP appraiser. I wanted to talk to you today about the COVID world for GPs and what's changed in the last year. So to start the session, I had a brainstorm about all the things that were different now compared to just over a year ago, so pre-COVID, what had changed. And I came up with a few new terms and buzzwords, which were completely different to us, things that have completely changed over the last year. And I thought it'd be useful to just think through all the many changes and then also to just focus in on some of those and think about which bits and pieces of our everyday practice have changed. So from my brainstorming session, I mean, one of the biggest differences has been that we now have our doors locked in practices. That's still the case. That came in at the beginning of the pandemic. So the idea being that we no longer had open access for people to just walk in, and that there's a triage process at the door. Anybody attending the practice, even with a booked appointment, has to talk through the intercom to the receptionist and go through a series of questions before they can be allowed into the building. And that was obviously mainly to reduce the risks to staff and other patients in the building during the peak times of the pandemic. That's been a huge change, that the practices are still quiet. Patients who do come for appointments, I think, find it strange that the waiting rooms are empty. And I think the downside to that is they probably think that we're very quiet and we're not doing very much. But I try and make it clear that behind closed doors, everyone's actually very, very busy. One of the other big changes has been wearing scrubs. We've all started wearing scrubs. That happened quite early on as well. The reason for this is so that we, at the peak times of the pandemic, we were taking scrubs home to wash them and not taking home any clothes that we'd been wearing at work. And that also was quite helpful for signposting to patients that we were in a different set of circumstances at that time and that we were working differently. I think people have felt on the whole quite comfortable carrying on wearing scrubs. It's almost become a uniform for us, and possibly they are here to stay. In our practice, one of the big changes was having shared lists. So as opposed to having our own booked clinics each day, we have a shared list which includes all the on-the-day phone calls, all the on-the-day e-consults, which I'll come to later. And this is a list that people pick off through the day. And on the whole, that's been quite popular. I think people feel less isolated than they did previously in general practice because they're working through a list with their colleagues, that they don't feel alone. We don't have an isolated on-call system as such anymore. There is an on-call doctor, but they are sharing the list with everybody else. Face-to-face, so minimal face-to-face consultations. That's varied at different times during the pandemic. I would say now we're in May 2021, so there's more face-to-face happening. There were times at the peak of the pandemic where we were having very minimal face-to-face contact. Certainly back in March and April 2020, there were very few face-to-face contacts, and we had to be able to really justify bringing somebody in to see them face-to-face. The e-consultation, which I mentioned earlier, was something that was brand new. That started in about April in our practice last year. So this is a new way of consulting with patients. I'll talk a bit more about that later. And also AccuRx, which I think different practices use different platforms, but AccuRx is what we're using in our practice. And that's, again, another way of communicating with patients. PPE, obviously everyone's heard about PPE and the ups and downs of PPE. It's hard to imagine now that we were ever worried about not having enough PPE and not having access to it, but the practice has a supply of PPE which we're still using for every consultation. We're still wearing face masks at work unless we're in a room on our own, and for any patient contacts, gloves, apron, mask, and then we're cleaning down rooms after we have consultations still. The amber room was a new concept that came along, and this is a room for seeing potential what were called hot cases, so somebody who might have COVID. Obviously the meetings, so remote meetings, remote education was all a big change for us back in March, April last year. and we suddenly had to adapt to doing lots of Teams meetings, Zoom meetings. But I think we've all become very familiar with that as a way of contacting our colleagues. The hot hub was another new concept. So every area had a hot hub for seeing potential COVID cases. And then later, and in a very positive way, we then had vaccine hubs. And so we still have a vaccine hub very close to our practice, which is where the majority of our patients are getting their vaccines. So I thought I'd talk a little bit more about e-consultation, because this is a very new concept, and for people who've not used it before, it can be quite daunting. I think our training in e-consultation was fairly quick. I think from one day to the next, we opened up the e-consult platform and we started to use them. And fortunately, at the start, patients were not very aware of e-consults, so we were only getting a handful of contacts by this means on a day-to-day basis. But it's very quickly become quite popular with probably certain groups of the population. And we're all noticing that it tends to be the preferred way of contacting us by certain people from certain demographics. And so there are pros and cons to the e-consults itself. So thinking about the positives initially, it can be very efficient. It's designed to enable doctors to potentially manage a case without having to pick up the phone, without having to have face-to-face contact with the patient. So there are certainly cases where that does happen. Simple, well-defined problems which are not concerning, where somebody doesn't need to be examined, or perhaps where they can send a photograph and have a diagnosis through the photograph. That can be a very efficient way of dealing with those sorts of cases. It does allow 24/7 access for patients. This has been quite contentious. I think a lot of our team feel that it's not really fair that it's left on over the weekend, and particularly bank holiday weekends. So obviously for patients, that 24-hour access is really important. The e-consult does actually triage problems. So if there are certain red flags, the patient will be signposted to actually seek advice more urgently. So somebody then entering crushing chest pain into an e-consult won't be triaged to have a call back within 48 hours. The e-consult will stop, it'll shut down, and it'll tell them to call 999 or 111. So it is very safe in that sense. There is some pre-assessment within e-consult which can be helpful. So patients complaining of symptoms of depression or anxiety are usually signposted to filling in a PHQ-9 and a GAD. And so when you do contact that patient, you've already got all that information at your fingertips, so that can be really helpful. And also in terms of triaging how soon you need to call somebody, if their scores are really high on PHQ-9 and GAD, obviously you're going to treat that as a more urgent case. There is a degree of data collection with e-consult. So there's automatic collection of data like smoking history, alcohol history. There's a series of questions the patient will be asked to fill in, and that provides data for system one. You can respond to an e-consult with a text message, and you can send links with advice. So that's part of the efficiency, I guess. An example of that might be something like a rash that looks like a typical fungal rash or a fungal nail. You might feel comfortable actually just sending some advice and through a link and a text message for something like that. E-consults also quite useful for admin requests. So people who maybe have already had a consultation about something and now just need a private referral letter, or they need a form to be filled in, or a letter, that sort of thing. It's really handy for. Those are quite quick e-consults to manage. And the other advantage, patients can attach photos, and the photos do stay on record. You have to be careful about the types of photos that we're collecting. We avoid having any, obviously, images of sensitive areas, sort of images of genitalia and that sort of thing. It's illegal to collect and store those sorts of images. So we have to be very clear with patients what they can and can't send in to us. But for skin problems, it's actually been quite a revelation how much of that we can manage remotely. So the disadvantages of e-consults, I think we all find they can be quite difficult with problems which are hard to define. So you can see sometimes a patient has really struggled to fill in the e-consult form, and they've hopped around from symptom to symptom, and what you end up with is quite a messy picture, which doesn't really help you in terms of making a diagnosis. And I think what we've all decided in those cases is just to pick up the phone. You know, there are clearly some patients, some problems which just e-consult just doesn't really work for them. The system can also get the wrong end of the stick, and it can lead patients down the wrong routes. And so people will tick a box, and suddenly that opens up a whole other area for them to answer questions on. And when you speak to them afterwards, they sometimes say, oh no, I didn't mean that, but suddenly I had to answer questions about dizziness, and I didn't really mean dizziness, and it gave the wrong impression. And you can usually tell when you read the consult if that's what's happening, because patients start to get quite frustrated, and they will make comments like, no, I'm not answering this question, I didn't say that. You know, there can be this real sort of mismatch between the patient and the platform, and so it doesn't work for all problems, it doesn't work for all patients. It's an advantage for the patients, the 24/7 access. I think for us it's potentially perceived as a disadvantage. I think Mondays can be incredibly busy with e-consult, and sometimes we find people have completed an e-consult on Friday evening. The problem's now gone away, but it's still sitting there on Monday morning for us to process. And so, you know, that can sometimes feel like a bit of a waste of time. Also, bank holidays, the Tuesday after bank holiday can be incredibly busy, and that causes a large workload to process. And in amongst that, there may be some quite urgent cases, but you're sort of looking for the needle in the haystack in a sense, with large numbers of e-consults in those sorts of situations. So the contract is set up that we have to have it on 24 hours, 7 days a week. And I think there's a lot of contention about that, and that's being challenged at the moment. Problems, as I said, problems can be out of date. So something that somebody completed on a Friday, it's gone by Monday, but we're still processing it. There's still a certain amount of work to be done to establish that it's no longer a problem. What we are finding is that people have described e-consult as almost another lane on the motorway. So it's not necessarily dealing with the same problems, but just in a different way. It's almost encouraging more access. So people probably have a lower threshold for consulting about quite minor issues, rather than what they might have done in the past, which was to try to self-manage initially, maybe speak to a friend or family member, or speak to a pharmacist, or look online. A certain group in the population do find e-consult very easy to use. If you're very familiar with IT systems, it's quite easy, and I guess being able to get that response within 24 to 48 hours is very satisfying. And so I think people's threshold for actually contacting us has lowered. So AccuRx is another new IT tool that came about around the same time as eConsult. So they're not linked, they're two separate platforms. AccuRx is something which it's like an embedded texting messaging system which links in with System 1. So you open it up at the same time as you log into System 1, and then the two interlink with each other. And it's a way of contacting patients by text message. The difference from a normal message on System 1 is that you can leave it open for a response. So the patient can, if you tick the box to say patient can respond, they have, I think it's up to 28 days to respond to you. So you can have a two-way texting conversation, even possibly whilst you're doing something else in the practice, and have that communication with the patient without the need to pick up the phone. You can send links, you can send documents, so referral letters can go through AccuRx, you can send forms to get blood tests done as attachments. So it's set up in a very convenient way. There's all sorts of ways of using it for efficiency, really. I think it's generally popular with patients. I think people nowadays, a lot of patients are involved in remote meetings all through the day at home, and they can't necessarily come out of those meetings easily, but they can perhaps respond to text messages quite easily while they're in those meetings. So I think it is quite popular. The photo attachment option is very useful. At peak times in the pandemic, we've even had people sending in photos of the backs of their throats, and amazingly, you can get quite a good view if somebody takes a photo with their own phone in good light, sufficient to diagnose tonsillitis. So that's been very helpful, and those photos do stay on System 1 in the long term. So it can avoid the need for a face-to-face or a telephone consultation. As I said, you can send letters, you can send medical certificates, and there's also a really nice function which is being able to delay messages until 7:30 the next day. I think certainly in our practice, we've all ended up working quite flexibly because of all the pressures of the last year. You know, sometimes it's just been very busy. We've ended up doing work from home. Sometimes we've been working from home because of having to isolate. People have had childcare issues and not been able to come to the surgery. So there's all sorts of reasons why we've had to work quite flexibly. And so if you're finishing off some work, you know, in the evening, and it feels like an antisocial time to be sending the message, you can tick the option to say, delay this message until 7:30 the next day. So that's quite a nice way of doing your work at a certain time, but also not contacting patients in outside of normal surgery times. So those are the advantages about QRX. I think it's been less contentious than eConsult on the whole. So disadvantages, I think sometimes the text messaging can work almost too well, and sometimes you end up with sort of toing and froing to the point where you feel it perhaps would have been easier just to make a phone call. So as an example, you might send a message to a patient, ask a question, leave it open, they respond, and they ask a question when they respond, and so you respond to that, leave it open with a question, and they respond to that with another question, and so you can end up in a backwards and forwards text messaging situation where it probably would have been easier just to speak to the person. We've had a few occasions where text messages have been misinterpreted. So I think text messages we tend to send them out quite quickly without necessarily reading them several times over to just check that they read okay. But I think we've all been conscious of being quite sensitive about sending text messages. So we try and start off by saying something like, thank you for contacting us. I'm sorry you've been troubled by this problem today. Because otherwise the text message can feel quite harsh if you just send a message saying, here's some advice. And the worry is that people feel a bit as though they're being dismissed by that in comparison to somebody picking up the phone and speaking to them. So we try and be very polite with the text messages, but I think there still can be open to misinterpretation sometimes. I suppose another disadvantage that it's another way of communication with us, so it's another thing to be checked regularly. So you've got your instant messages, you've got your tasks on System 1, you've got your emails, you've got your paper messages, and then you've got QRX to check. But because it's live, the messages just pop up in front of you, very much like a normal text message. And so I think the tendency is to just quickly look at them when they come in. So we don't tend to have a big backlog of messages to be checked. I talked a little bit about inappropriate images being sent. So we try and, there is some guidance you can send throughout QRX around how to take good photos and what type of images should and shouldn't be sent. But if people do send inappropriate images, we inform them that we're deleting them, we're not saving them on the system. And that doesn't seem to have been a huge problem, really. And obviously, with all of these methods, not all patients use text messaging, not all patients have mobile phones or smartphones, not all patients are able to use the photo part of their phone, even if they have a mobile phone. So it's not for everybody. And I think all of us have been quite worried about the potential exclusion of some people from these new systems and ways of communicating with us, and the overall long-term impact of that. As I say, it's something that works for some people really well, but for a certain group of the population, it just isn't really going to be their preferred way to contact us. So thinking about face-to-face consultations, Mandek, I just need to stop to get some water. So the next thing to mention is the change in terms of doing less face-to-face consulting. So as I said before, this has varied through the year. There have been times where we've done virtually no face-to-face consultations, and then times where we have been more relaxed about bringing people in. And it's very much depended on the perceived risk in the community at any one time. So, for example, now we're in May 2021, and we probably have a much lower threshold for bringing people in to see them face to face compared to when we were back in January, February this year. We still have the doors of the practice locked. We still triage people before they come in to make sure that they're not at risk of having COVID and bringing that into the practice. We have to still think about staff and other patients in the building, obviously, and patients do wear masks when they come in. We wear PPE. It's become the norm to clean all surfaces and equipment after every consultation. And as I say, the screening questions for COVID. So we would do that on the phone before we bring somebody in, but the receptionists are also trained to do that through the intercom when somebody comes to the door. If there's any doubt, we use what's called the amber route. So this was set up at a higher risk time back in April, May last year, where we were still seeing some patients who potentially had COVID, but for whatever reason, maybe before the hot hub was in place, so there was nowhere else to send them. Maybe it was a child or a baby, someone that we thought that was a very low risk that they had COVID, but they did have a fever, for example. So we did feel that we needed to see them, but also to be cautious. And so in our practice, this involved patients coming to the back door, calling a mobile phone number to let reception know they were there, and then they would be let in and escorted through to a room at the back of the building, and they'd be seen in that room. That room would only be used for potential hot cases, and then after the room was used, it was fully cleaned. And if we felt the person may actually have COVID, then we would do a deeper clean of the room afterwards, and then nobody else would use it. So there were lots of protocols in place around cleaning and which rooms to use when. I think it was challenging when we were seeing less people face to face, because there is something irreplaceable about actually just seeing somebody, even compared to on a video, actually seeing somebody walk into the room. I think we all realised how much we based our decision making on that initial impression of somebody when they arrived, and without that it's quite hard to feel reassured that somebody's not very unwell. So there were situations where an examination was essential and it couldn't be done remotely on a video, and so we were having to bring people in. There was guidance to say that we shouldn't be looking in people's throats at all, and that was very hard as well. Although we did manage quite well with getting people to do either opening their mouth very wide on a video consult, and we could see their tonsils that way, or people taking photos and sending those in. So there were ways round things, but it all felt quite challenging at the time. With home visits, we probably had more home visits during the pandemic, because obviously there were people who were shielding, and people who older people who were less keen to come into the practice for a face-to-face consult, and we were also less keen for them to be coming in. So the need for a visit obviously has to be triaged and the COVID risk considered. One way of trying to manage the risk was to try and take as much history as possible beforehand, and then really just doing the visits involving the bits that couldn't be done remotely. So explaining to the patient beforehand, when I come in, warning them we're going to be in PPE so they don't get a shock on the doorstep, and explaining that we would just be coming in to have a feel of their tummy, maybe check their blood pressure, and that would be it. And then actually calling afterwards to do the conversation and the follow-up. So it was a little bit odd, but it was trying to minimise the risk as much as possible. We have had a few patients who are using CPAP or NIV at home, and those are what are called aerosol generating procedures, AGPs. So in theory, if you're in a room with somebody on CPAP, you should be wearing FFP, which is more protective than PPE. And we don't have access to FFP. So that was just something to be mindful of about, you know, going into home visits in that scenario. We were supposed to be asking patients to wear face masks, and most people were respectful of that, but I think in a situation where somebody was refusing, it was quite difficult to not proceed. And obviously cleaning all equipment and taking PPE off and putting that in a waste bag before leaving the person's home. So quite different from our usual visits, I have to say. But I guess it's become the norm now, and people are quite used to us turning up on the doorstep in PPE. We did have access to hot hubs after a while, and hot hubs were able to visit patients who possibly had COVID. So if we felt through a telephone assessment or a video assessment that somebody potentially had COVID, then we could refer to the hot hub and they would have a visit through the hot hub. And at one point we had black cab taxis going around with doctors, and everybody would do shifts for the hot hub doing the home visits. So that was for a period of time. Obviously the need for that then reduced, and it was something that was then stopped. So within the practice, I suppose the changes, we've gone through the main changes already, but I suppose day to day, we're now all wearing face masks, apart from if we're in a room on our own, maybe doing telephone consults. But as soon as somebody comes into the room, we put a face mask on. We've got the locked doors, the triage at the door. Receptionists now have perspex panels and can wear visors if they choose to. We all do a lateral flow test twice a week, and initially that was in the practice, but we now all have access to tests at home, so we do that and then we self-report our results to the practice, and that's been quite effective. We've picked up a few members of staff with asymptomatic COVID, very early stage COVID, through the LFT testing. We've had to be careful about shared areas, so the kitchen area, the meeting room, hasn't really been used in its traditional way for a long time now. We don't congregate in the meeting rooms or in the kitchen area anymore. We have signs up saying the maximum number of people allowed in each room at any one time. And fortunately, we have quite big clinical rooms, so we've been doing tutorials in our rooms, but wearing face masks and 2-meter distancing. We had to set up a one-way system through the practice to make sure that there was a one-way flow. And then, as I mentioned, meetings have all been remote, so through Teams or Zoom or Google Meet. I think because of the shared list and the flexibility, you know, not now having pre-booked 10-minute consultations through the morning and through the afternoon, there is a lot more flexibility to join meetings and to join education sessions. But I think we all also find that the commitment to join those things is probably lower because you're not having to travel to a place and be there for a certain time. You can literally dial in on the spot if you happen to be free. So there's probably a lower threshold for sort of not attending things sometimes because you've got that flexibility, and you either forget or you've booked into something with good intentions and then you actually don't manage to free yourself up to do it. Whereas in the past, booking on a course, you would have made sure you had study leave and you actually went on that course. So there are pros and cons to that. I'll just say a little bit about working from home as well. So this is obviously a new concept for all of us a year ago. I think things have moved on quite a bit since the early days. I think looking back, the first time I had to do it, I was isolating because we had symptoms, but it was at a time where there was no access to testing. And so we were in full 2 weeks isolation at home, and I had booked clinics. And so I was trying to do phone calls to those patients that were booked in with me on a Sunday afternoon to sort of try and get ahead of the week. And it was it was very strange. It felt like a complete mix between work and home life, not very healthy at all. It was quite stressful. Patients were very appreciative, and I think at the time it was all a bit of an emergency situation. So I think people understood that things were changing, and that there were all these pressures on our time. I think things have moved on a lot since then, and now most of us in the practice have some time within the week where we do work from home. So I do quite a lot of tutorials with my trainees working from home, and we've all done phone clinics, sometimes video consultations from home, a lot of meetings and sort of, I suppose, education sessions that I do will be from home. And I think also because we're having to be careful around space in the practice, that there isn't as much room anymore because of having to be safe about how many people are in. You know, that we have hot desk spaces, but we can't have people hot desking close together. So the capacity of the building is reduced, and there's a bit more pressure to work from home when we can, just to free up space in the building. Various issues, various challenges, I suppose. You know, privacy. If you're actually isolating and the whole family's at home, that can sometimes not feel like a very safe or private space, particularly if you're having quite personal discussions with patients. I think for patients particularly, I think hearing background noise and family noise in the background can be a real distraction, and it can feel for them as though you're not perhaps fully focused on what you're doing. Being at home, I think it's a myth that it's easier. I think often when you're at home, there are other things pulling on your time, like the homeschooling and the housework and, you know, jobs that need doing around the house. And when you're at work, you don't have to look at those things, but when you're at home, you're surrounded by you know, all the other jobs that need doing. So it's quite hard to stay completely focused on work. It can feel very isolated. People who have been shielding and working from home, or working from home every day, must have found it very hard in terms of that lack of social contact with their colleagues. It can also feel like an invasion of your privacy. So people are seeing inside your home. Obviously, you can change your screen to hide your background, but I think for a lot of consultations, there's definitely a different dynamic if you're doing them from home as opposed to being in a very clinical environment. There is flexibility around working from home, so you get back your commute time in some way or other. But I think that's why it's important to take breaks, because sometimes you find that you actually work longer hours at home because you don't have your commute there and back. So you actually just fill that time by doing work. So it's really important to try and have a routine, to try and take breaks, try and take some sort of exercise, and dialing into meetings, really important. So making sure that you dial into the practice meeting every week, keeping in touch with people, staying connected, all really important. So I think that's lots of skills that we've all learned, I guess, through the year and having to work from home. So that's the end of the slides. I think where we're at now is probably slightly different to where we were when I wrote the talk initially. We're now in May 2021 and things have relaxed a little bit more. So I don't see many video consultations happening anymore, because I think people find it easier to just bring patients in, whereas perhaps back in January, February this year, there were a lot more video consults and we were not bringing patients in as much. But I think what we've learned through the year is how to flex, so how to respond to the needs of the time and the restrictions at the time. And all in all, I think that there've been lots of positive changes from the pandemic. I think the way that the pandemic has challenged our traditional ways of working, the old style pre-booked 10-minute appointments set in stone. I don't feel that not having that is necessarily a disadvantage. I think there are lots of different ways that patients can access us now. And I think what we have to be really careful of is making sure that there is equity around that it's not just certain groups, certain age groups who are IT aware and able to contact us in the new ways, and that we are mindful of people who will find that more challenging. But on the whole, I think the flexible way of working, being able to devote 2 minutes to an e-consult and then give someone else 20 minutes or even an hour for a home visit makes much more sense than the 10 minutes everybody was allocated in the past. So it's definitely given us a lot more freedom to have control over how we work and how we use our time in terms of the actual clinical need of the patient. So that's something that I think will probably stay with us. And AccuRx, eConsult are also likely to stay with us. I think eConsult will remain a bit contentious, and we'll see what happens with that in terms of the potential increased workload that has brought. But on the whole, I think practices are good places to work and environments where people are, on the whole, rising to the challenges and enjoying some of the changes that have come as a result of the pandemic.